Good morning, everybody. It's great to see you all on day 2 of the 18th World Congress of Anaesthesiologists. My name is Wayne Morris. I'm from New Zealand, and I am the current president of the World Federation of Societies of Anaesthesiologists. I'm going to be co-chairing this very important session with Professor Adrian Galb, who is the immediate past president of the WFSA. I'd like to say first, congratulations to all the hardy delegates who went on the fun run this morning. They got down to the marina area before 6:30 and we had a wonderful walk or run around a spectacular part of Singapore. So I hope all of you get a chance to see that part of Singapore during your stay here. Welcome to this Harold Griffith Lecture session. This is the premier keynote session of the World Congress. We have 2 fantastic speakers, Dr. Jannicke Mellin-Olsen and also Professor Kevin Fong. I'm going to introduce Jannicke and Adrian is going to introduce Kevin. This session commemorates Dr. Harold Griffith, a Canadian anaesthesiologist who was an amazing clinician, also an innovator and a scientist in the field of anaesthesiology. And very importantly, he was the first president of the World Federation of Societies of Anaesthesiologists. Let's hear more about Dr. Harold Griffith now.
Welcome to the Harold Griffith Lecture. This keynote lecture is named after and honors the founding president of WFSA. Dr. Harold Griffith, a Canadian-born anesthesiologist, transformed anesthesia practice in 1942. He and his resident, Dr. Enid Johnson, used curare for the first time during anesthesia to produce muscle relaxation. This was almost 100 years after the first demonstration of ether anesthesia by William Morton. Dr. Griffith revolutionized the practice of anesthesia by demonstrating that a substance, which until then had been considered a poison, could be safely used to produce muscle relaxation for surgery. Harold Griffith's groundbreaking use of curare is one of the most important advances in our specialty and an unparalleled legacy in medical science. The introduction of muscle relaxants, a development often referred to as before and after Griffith, reduced anesthetic requirements, significantly increased the scope of surgery, improved operating conditions and decreased morbidity and mortality. Harold Griffith dedicated his life to anesthesia and made many other significant contributions to our specialty, which were widely acclaimed and for which he received many awards. In the early 1950s, Dr. Griffith became involved in what he probably considered to be his greatest contribution to anesthesiology: the creation of the World Federation of Societies of Anaesthesiologists, WFSA. He was elected president at the first World Congress of Anaesthesiologists held in the Netherlands in 1955, and, at the second meeting, in Toronto in 1959, he was elected founder president. Today, we honor Dr. Harold Griffith and carry forward his legacy, his pioneering spirit, and his dedication to our speciality, by advancing education and research in anesthesiology, and by uniting and empowering anesthesiologists around the world to improve patient care.
Thank you. It is now my honour to introduce our first Harold Griffith speaker for this session, Dr. Jannicke Mellin-Olsen from Norway. Jannicke is a world-renowned anaesthesiologist whose career is a testament to innovation and dedication in medicine. She was president of WFSA from 2018 to 2020. Her career includes serving in war-torn Lebanon with the United Nations, chairing the WFSA Education Committee, and leading efforts to increase access to safe anaesthesia worldwide. She led the development of the Helsinki Declaration on Patient Safety in Anaesthesiology, which was launched in 2010, and she has worked tirelessly to improve patient safety and quality in healthcare. Jannicke's work has been recognised by many organisations, and in 2021, her country, Norway, made her a Knight of the First Order of Olav, Norway's highest civilian honour. It is now my honour to invite Jannicke to deliver her lecture, Quality of Care, A Human's Perspective. Please welcome Dr. Jannicke Mellin-Olsen.
Thank you very much for that very nice introduction, and thank you very much for inviting me to give this important lecture in the honor of a very special person. Just a little bit about my own background. I have, like Harold Griffith, a passion for organizations, believing that anesthesiology and medical organizations, it's important for us to come together and share and become better at our work. And I am Norwegian, which is one of the most richest countries in this world. I know that's a bias of mine. And also we have a very low gender gap, which I have benefited from in some matters. Well, I was given the task to talk about quality of health services. And this is what the WHO lists as quality factors. But I was not tasked to deal with all of them, but the human perspective, people-centered, responding to individual preferences, needs, and values. And that is what I'm going to talk about now. I'm going to talk about it from a general perspective, patient perspective, relative, healthcare worker at the front end, and then some general terms. If we look at the coverage of essential health services in 2021, it was not fairly distributed. And poor quality care, particularly in low and middle income countries, contributes to 15% of all overall deaths. So it's not only lack of access to care, but poor quality care as well. And I think when we meet our patients, I think the Patient Safety Movement Foundation, who brings together all stakeholders in healthcare to reduce the number of unwanted deaths in hospitals, they say one of the guiding principles, promote respect, dignity, compassion, and love in all actions and behaviors. That is a bold statement for our profession. And a very important base of that is the What Matters to You campaign. What matters to our patients might not be what we think is most important to them. So better to involve them. And one of the things of here, I'm going to talk about humans, and the human I'm going to talk about is myself. Because I'm sure, like me, in this audience, many of you have your experiences from all those parts of healthcare. And this is me 5 years ago at the Patient Safety Movement Foundation Summit. We had a wonderful evening. And the next morning, I did a run on the Huntington beachfront side, and I noticed something was not right in my body. So I got home, and before I knew it, I was under investigation for 2 individual cancers. One of them was a metastatic pancreatic cancer, which was an incidental finding to a sarcoma in the uterus. So now suddenly the world is turned upside down. I am the president of the World Federation, 1.5 years to go with my term, And what shall I do? I have seen so many patients dying from pancreatic cancer and in great agony, but they are fine until they go down the drain at the end. So should I just try to complete my tasks as a World Federation president until it became too late and bye-bye, which was supposed to happen in a couple of months? Or should I receive treatment? I was very fortunate to have an oncologist and his study nurse, and they respected me. What is important to you? Okay, we will go with you all the way if you decide to take treatment or not. And just to be seen and evaluated as the person you are was so important. So here I am, I'm receiving chemo and all sorts of things and trying to fulfill my work as a president. And by some miracle, I didn't die within a couple of months, but I had side effects, and many side effects. And one day I came for treatment, and he said, "How are you doing?" And I said, "Well, I'm fed up with this thing. Why not take out the whole shit?" And I knew that was not possible to do that because it was inoperable. But he said, "Oh, I thought about it myself." So the last day of my presidency, this is what I saw in the operating room. My colleagues had made syringe labels to cheer me up when they were going to try to do surgery on me. So I was a VIP patient. I was having here a meeting after a few days in the House of Lords, a hearing on global anesthesia from a hospital room. It was during the pandemic. But even though you are a VIP patient, you have to fight for yourself. The surgeons would go their rounds and they would say, "Oh, your hemoglobin is fine. Okay, CRP is low." And I had to say, "Yes, what about my thrombocytes?" "Well, it's 17. And what about my sodium count?" "Well, it's also 118. And they didn't check it. And you feel you want them to like you. You don't want to ask all these difficult questions. You don't want to be that patient. But at the same time, you have to fight for yourself. And that dilemma is not easy. And then we should remember that when we talk with our patients, the 4 good habits, which is a concept developed by Kaiser Permanente in the USA. Invest in the beginning, elicit the patient perspective, demonstrate empathy, and invest in the end. I'm going to take you through some of them. Elicit the patient's perspective. And that is when we meet the patients, what do you think? What are your thoughts about this? Let them help you to give the answers. What worries you the most? For instance, during anesthesia, you feel when the patients are feeling bad, and you see they are not happy about going under. And then, so what is your biggest worry about this? Well, maybe I won't wake up again, or I will be unable to move but being awake, and you know all these things, giving away control. Elicit it from them. What is important for you now? And this is something which I did in my hospital in the first place, because I hate standing up and looking down at people. I just don't feel that's a good thing. So then I used to sit down like this. But then why not make a stool so they can bring that stool over to the patients? And that became a national program. And so you can meet the patient eye to eye. It gives you a better perspective. And then one day in the PACU, the nurse came with the stool to the surgeon, and the surgeon said to the patient, "Oh, those nurses, they are so pushy." And then the patient told him, "Well, I think it's good. I don't feel very strong here, I'm lying." So she was so brave, and that's so correct. And we have also our colleague, Professor Ernil Hansen in Regensburg in Germany. He has this way of how to communicate, how our words can help comforting the patient. And then when we come with a mask, we can clash it down in the face, or we could put it gently like this. Makes a big difference. And this is something that Harold Griffith saw. He saw this when he wrote in 1937. I'm very much opposed to the practice of putting a patient on an uncomfortable stretcher half an hour before the time of operation and wheeling him in this embarrassing position through the corridors, only to wait in some anteroom until the omnipotent surgeon is ready to give him his attention. And yes, we bring patients in on a stretcher. If we have the head down, this is what he will see. Just to open it a little bit, the patient will feel much more in control. And back to our friend Harold. He said, patients are sensitive about such things as false teeth and the state of their hair or complexion. If it keeps up their morale to come to the operating room with painted lips and blackened eyelashes, I'll say, let them. They never know how bedraggled their faces may look after an hour or two of anesthesia, and no harm is done. Many times I have removed a toupee or wig after the patient is asleep and carefully readjusted it to keep up the illusion before the patient awakes. And I think this is also resonating with me, because many of our patients, when we think about cancer patients, for instance, what are they worried about? Pain. We can help them with that. But also losing their dignity, changing the way they look, becoming cachectic or like steroid types. So we have so many things we can do. Demonstrate empathy. And that is something important too. Here's an example to show the patient that you care. Here is there was a patient in ICU. I had about 5 months of training of anesthesia, and he had a leak after being had surgery for esophageal cancer. And then I took care of him and he went up to the ward, and then he was going down again for new surgery. I met him in the corridor and said, next time I want the best anesthesiologist in this hospital to take care of my anesthesia. I want you to do it. And I knew I had 5 months of training. I knew I was not the best. But the reason was, of course, that I showed him and his family that I cared about them. And many times I have also shed a tear in ICU when somebody is dying, or when somebody tells me a horrible story. And that doesn't take away my position as a good anesthesiologist. On the contrary, I show them that I care. Obviously, I should not be the one who's sobbing the worst in the room, which another time I did, all of us, we do at some point when we do central venous lines, there will be a pneumothorax. And to me, it happened to the worst pain patient who was 35 years old. She brought her mother with her to take care of her, and I did it, not only on one side, but on 2 sides. This is obviously a long time ago. And I felt so bad afterwards that I went down all the time. How are you? How are things going? And in the end, the mother and the patient start, well, it's all right, it's not so bad, and blah, blah. And then I thought, okay, you are doing it too much now, it's too far. That they are comforting me. So, I mean, there is a balance. But here are some very wise men from the 18th century. It's the Norwegian author Arne Garborg, "A sick man knows much of which a healthy man has no clue," and Sir William Osler, who is supposed to have said, listen to the patient, he's telling you the diagnosis. And that is one of my main messages. When we are listening to the patient and taking them seriously, it's not only to be nice to them, it is to provide better care. We are better doctors if we are listening to what they are saying. And that goes not only for patients, it goes for relatives. And here is me. I'm 4 years old. My mother drew that picture, and my parents are on the right side. I had a young brother, newborn baby, born with esophageal atresia. I was 3.5 years old, and he had to be in the hospital for most of his life. And my mother knew she had to be there if he was going to make it, if he were to make it. But nobody could look after me and my sister of 2 years old because my father had to work to get money to support the family. And I said, I look after my sister. So I was at the age of 3.5 babysitting my little sister, and they really didn't have any choice, and they knew I could make it. I made it. Then he was in for surgery, and my mother told them that his surgeon was away. Please ensure you don't remove this gastric tube, because his surgeon said that it was so difficult to put it in, it must not be removed. And then it was difficult mothers, you know, they're always pushing. They took it out, put it back into the peritoneal cavity, and my brother died. That was the end of my childhood in many ways. And I had learned one lesson when I was at this age with my sister here, and that is, you should always listen to concerned parents or relatives. Okay, there are hysterical mothers, they exist, but they are a diagnosis of exclusion. Listen to them, take what they're saying seriously. So I decided to become a doctor and make a change. And this happened more than 60 years ago, so you should think now things are much better now. But again, this is for the Patient Safety Day in Geneva at the World Health Organization in September last year. There was a meeting where, because that was about patients, and there was this meeting, a working group, Patients' Experience of Harm, Lessons Learned from the Healthcare System. And all of these are people who are involved in this listening to patients and relatives. And we heard stories from South Korea, from United States, from Thailand, from Uganda, from UK. They were horrible, horrible. Patients coming to the hospital, not being listened to, sent home, came back in dire conditions. I mean, it was physically painful to listen to all those stories, what happened today in all our countries. And some of us even started to cry, and these are people used to hearing things. So we need to listen to patients, and part of how to do that is, of course, to feel safe in our own culture. And if you see this man, he is my first professor and mentor, Sven Erik Gisvold from Trondheim, Norway. He's preparing waffles for the nurses. But he was asking so stupid questions when I was young. I was thinking, you should know the answer to those simple questions. You are the professor. And only later did I realize that the reason why he asked all those questions was to make us feel safe. No question is too stupid to ask. And he was very much able to create a department where input was welcome, all our concerns, if we have trouble with patients, speak up, support each other. So we will almost have a competition to disclose our problems or errors in the thing. Safe culture. And that is very important, that we support each other, that we realize that mistakes and errors and things happen to the best of us, if the conditions are right. Any of you, it will happen to, or it has happened to. But try to support each other. We are all in this together. Today, me, tomorrow, it could be you. And this is something too, we have to feel safe in our environment. Caring for doctors, caring for patients. And I feel this is an example from UK when they are trying they have problems there, but that is for so many of our countries, that we have problems, clinicians are not being listened to, our expertise is not welcome in many ways. But if we could do like Vined Nayar, I've also seen that it has been some in anesthesiology news in the USA, some more about putting more power to the clinicians, that we have more influence. And many a time have I felt bad in my country that why don't they listen to us? We are experts, we see what the issues are, but there are others who do that. What this Vined Nayar did, he turned everything upside down. If you are sure that your employees are happy. If you support them so they can do their job, they see what the issues are, you can help correct them, then it went much better with the company. So engaging us and empower us is important. And here is an example of how I feel that we as healthcare professionals are not necessarily second victims, but first victims, and how. Yes, they were going in one area of Norway. They were going to introduce a new electronic health system. It was based on Epic from the United States, which many of you would be familiar of. And we, or the healthcare workers at the front end, they saw this is not going to run. This is going to be a disaster. And even at the point they went out to the streets to demonstrate with torchlights, please stop it, stop it. But then the authorities, you know, just those healthcare workers, they do, so we will do it. And it cost billions and billions and billions. And it's become a disaster. It's more than 1 year ago now. Patients die, their referral letters or test results are just disappearing into the air. And who are making those so-called errors? Who had to call the patients and relatives? Oh, I'm sorry, your cancer has gone too far now, but it was lost. It's us. Those people, or them then in that region, those who went out to the street and tried to stop it. And it's still an ongoing thing. And it's not only in my country. More than 10 years ago, I was part of a group of physicians in Norway making an organization to reclaim the profession. We saw how things were when everything was into money and new public management and so. I thought this would be easy to change once we had pointed the finger on the problem. No, it's so hard to change the system. So I think what we have talked about is sometimes we feel powerless. And also when I spoke about my professor, I have told many times about him. People will say, okay, that's nice, but you know, my professor, he will never be that, or head my healthcare system or whatever, it's horrible and so. Yes, I appreciate it's not so easy, but you are yourself. You can start with yourself and do as best as you can in that system. Not easy and not always going to be right, but that is the best we can do, honest to what we have to do. So we know, now I've talked about patients, relatives, healthcare workers, and we know that 24% of the world's population live in fragile contexts, not delivering quality and essential health services. And this was in 2019. They made the global development goals and so, and things are not improving well. Partly due to the pandemic, but we are not making the progress that we should make. And here is what we in the WFSA are doing. To try to work with the WHO, governments, and ourselves come together, and in order to get there, we need numbers. So the WFSA in 2016, you will find from there the workforce map, and we at that time saw how big the gap is, mostly in Africa, south of Sahara, and Southeast Asia. We have redone that survey now, and it is impressed in anesthesia and analgesia, you can see it now. Because if you do not have people to do the work, how can you deliver high quality services? But we get nowhere when we say we are too few. We have to have figures. And at that time we calculated that 10 years ago, Now, to have a minimum number of providers, we would need 136,000 trained physician anesthesiologists. 136,000. Where are we going to take them from? Okay, we can use nurses. Yes, but nurses are also in shortage. And my husband, who's a war surgeon, he was working in South Sudan. And he was working in a war zone there, and he told the nurse afterwards, okay, give this patient 3 tablets of this painkiller after surgery. And the nurse said, 3? So she didn't even know how to count. So we have a big job in front of us, ahead of us, because we have to start with basic education to get people ready to do the work and to train as anesthesia providers. So it's a huge task, but we have to go there, and we have to follow it with numbers. The same goes for perioperative mortality and deaths. In the WFSA and together with other partners, we have worked with Lardal Global Health and the Lardal Foundation at Utstein meetings to try to agree on numbers, on criteria for how to count, measure and report and build on perioperative deaths. Very important work. And we have to go to the governments with that. All we do, we need to work on anesthesiology. We are the ones to claim that those 5 out of 7 billion people in this world who do not have access to safe anesthesia and surgery when they need it. They're not going anywhere unless we take that responsibility. But it's not always so easy, because you have here water, simple things you need to provide health services. Many hospitals in this world do not have access to water. Here is an example from India some years ago. It was drought. At the same time, there was a cold blizzard in Texas that hospitals in Texas went out of water. And some places the water is dirty. How can you provide safe healthcare if there is no water? The same with electricity. If you don't have access to electricity, how can you give good quality healthcare? Well, you have to do the best you can with the resources you have. But that's another obligation. Here is from Russia. These people in this, in Blagoveshensk, I cannot pronounce it, they were doing open heart surgery while the hospital was under fire. They completed surgery and put the patient and evacuated everything. This is happening in many countries that it's not safe. Then we have natural disasters. I have been able to work in some of those, which many of you have had in your own countries. And this is from just last autumn. And our colleagues are trying hard to provide safe health services when they don't know how are things going with their families and so. They own houses. Are they standing? And I must pay my respect to all of you who have done all these things in that situation. But it's not only that. We have the Geneva Convention, war zones. I have also been working in war zones. And we are protected on paper by the Geneva Convention. There have been much talking lately that it's not being respected in so many areas of this world today. This is true, it has to change. But unfortunately, this is not a new thing. If you read from the history, our colleagues in previous times have always also been affected by war and not always protected. So again, all of our colleagues who just now and in the past have offered their lives on stake to help others in war zones. My respect. That also goes for you who have been in war zones at home at terrorist attacks. So a third problem, or fourth or fifth or sixth or seventh, is corruption. Because how can we provide safe and high-quality services if the money is going to the pockets of some people? And imagine, more than 80% of the world's population live in countries with serious corruption problems. It's amazing and not easy. I'm approaching the end now, but I want to say here with Harold Griffith, what we have, what the patient safety movement has, promote respect, dignity, compassion, and love in all actions and behaviors. This is Harold Griffith. We heard a little bit about him before. Read this book, which has been referenced earlier, because it's amazing what warm, human, kind being and how much he was involved in patient safety and so. And this is what WFSA is about, and that was his passion, that is my passion. Universal access to safe anesthesia. And it's your passion and your mission. We are the Federation, uniting and empowering anesthesiologists around the world to improve patient care. That is what we are doing right now. And to end, because I was told I had to tell about myself at the end, and that is, okay, my cancer is sleeping. I told a colleague, well, how are you? Yeah, my cancer is sleeping. And he said, maybe it's dead. The oncologist said, yes, but there is a reason why we are still checking you. But meanwhile, I'm here, I'm enjoying with you, and you say you should live today, but I would not underestimate that you have the courage to plan for tomorrow as well. Thank you very much.
Give you. Jannicke, you're an inspiration for all of us. You're a friend of many of us, but you're also an incredible, amazing, gifted, rare role model for all of us. For everyone in this room and beyond, you are an example of what we should all be.